All right, we just started. You're on.
Okay, so. Easy. Put it here. This is what I do with the, whatever you call this blender that you hook this up. This is what I do. Okay. I'll try it. The bullet. All right. Barely, right? So, I know that you all read the chapter, right? Yes. Did you all?
Yes.
If you didn't, this is kind of what happens when you have what covers the lungs full with air or water or whatever. You just can't do much, and it takes a lot of effort. It took me a lot of effort to do that. Now, another thing that kind of what happens, what I want you guys is to take short breaths, normal rhythm, breathe normally, but your breaths should be like this. That's it. Like, boom. This is the beat of your breath. Boom, 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 boom. But leave time in between. So go like that. I don't say no. So that is if you can barely inflate your lungs. That's the rate of your breath. Imagine that without effort and pain. Not fun. So we're going to talk about that today. Sorry that I left you with that feeling. Another thing that's really important to know is one of my sisters, I have a ton of siblings, but one of my sisters is an actress. And breathing like that makes you feel stuff. And when you're angry, you breathe faster. So what happens is that if you're breathing little, you're making an effort, you're also getting anxious, there's a ton of things going on. So we're going to talk about that more in the control side of things, but what I want you to know is that it's hard. Things get compromised. And we're going to talk about things that are wrapped by a sac and that get, packed with stuff. And the things inside the sac can't work. Chest trauma, that's what it is. So, I'm going to talk about anatomy and physiology, assessment and treatment. So, the lung, chest, and the cavity. So, on the chest cavity, so our thoracic cavity. But it's protected by the ribs, which is really good because you can do this. Try to do that in your stomach, it's not fine, right? But here it's protected. The sternum here in the middle, right? What's inside from the frontal view, the things that, there are many things that matter. One thing that you see there is the lung. Somebody was asking about the diaphragm. This is the diaphragm muscle. And I'm going to show you an animation of how it moves. Sometimes it's hard to understand that it contracts, so your torso expands, and that's kind of weird, but that's how it happens. Now, something really important to notice in this thoracic cavity is that at the margins here, between the lungs and the ribs and the muscle in between the ribs, the lungs have a layer here, right? Pleura, we can call it pleura. And then the muscles and inside the ribs also have that membrane. And then in the middle, there's the pleural cavity, right? And it's full with fluid, if you will, right? So some liquid that acts as fluid. Now, the diaphragm moves like this. So then it relaxes and then it contracts. It contracts downwards, right? So then, just like a Play-Doh, right? If you pull it here, it's relaxed, but if you contract it, it goes sideways, and that makes the ribs, expand, which basically in turn opens up a vacuum that is filled with the air that comes in through your lungs, right? All right. So we saw the lungs, pleura around the lungs, the bag that holds the lungs, if you will, right? And then the heart also has another sac, another bag, right? It's the pericardial sac. Why do they have these bags with lubricants, you think?
Because it moves, so to not have friction.
To not have friction, right? That would be painful. That would be really painful. It's the heart that beats every single second, right? Hopefully not a lot more than that. It would get pretty worn, and it would hurt, and it would rupture, and whatnot. So, important for chest injuries, and I think that this ties really well with what Kenny was talking, is, first of all, Kenny was talking about how to assess the acute abdomen and all those injuries, right, and how to treat them. Well, the main thing to start acting like the other lectures versus acting as you would act here is you have to establish a mode of injury, right? What happened? Is it or a nature of illness? Is it medical? Is it a blunt trauma, whatever? And that will guide you as to which of these treatment techniques to choose, right? Okay, so the mode of injury for chest injuries, this is protected. This is armor, right? So it requires a lot of force, okay? A lot of force, which will tell you something too, right? If you punch, so I was thinking like, what prop do I bring? And then I ended up with buying Walgreen incandescent balloons. But I thought about piñata at one point, right? Because it's like a chest cavity. It takes a lot of force to break that thing, but once you break it, all the candy comes out. So you gotta be really, really careful. Injuries can be closed or open, right? So open, there's a hole, some hole. Closed, no hole, it's inside. Contusions, anything with contusion is, pulmonary myocarditis. That's a big blunt to the lungs or to the heart, right? Rib fractures, you can have, it hurts, of course. They can rupture things. So if you fracture a brittle thing, that thing ends up sharp, and that can puncture these sacs that we've talked about, this pleura. And also you can get flailing chest. And then you have commotion carditis, which is a blunt trauma to the heart, and it can cause death pretty like the battery in your car. It's like it dies, when it dies, right? So I don't know that we have a lot to do with commotion carditis, but if we have time, of course, load and go. Most of these things are going to be load and go.
That's what happened to Hanlon of the Buffalo Bills.
Yeah.
The defensive back got a blunt trauma to the chest that caused sudden death, but he was resuscitated.
Yeah.
Luckily.
Oh, yeah. So that's we're gonna see in the treatment. That's the thing. That's the thing to do. Just go CPR, right? Now this is what a flailing chest looks like. So you're trying to breathe in, instead of expanding your thoracic cavity, it expands the bottom of it, but then the ribs around here, they don't move. Why do I show this? Well, because hopefully we're not likely to see any of these things, but if we see them, I want you to know what it looks like as opposed to that diagram in the book. All right, sucking injuries. So this, I don't know if you can see, but there you'll see bubbles there. You see that? Okay, so that's a sucking wound. Anyways, we're going to talk about that. We can have certain fractures, like I mentioned. You can have an aortic rupture. So I showed the lungs and the heart, right? But then from the heart, you have the vena cava and the aorta, right? What happens is if they rupture, you get less blood, which leads to a hypovolemic shock, right? So hypovolemic, low volume, right? So no blood. And your heart beats like crazy because it wants to supply the blood. It can have deferred pain to the arm, and different blood pressure, in the arms, right? So if you take the blood pressure one and the other one, and I mean, all things lead to this, right? And they're drastically different, then you might suspect this. You have pneumothorax. So the cavity here, right, the sac, is filled with air, and that doesn't allow your lungs to expand properly, right? You can have also the hole in the chest cavity can bring air in and inflate that sac, right? The pleural cavity. And then it narrows, it leaves less room for the lungs to expand. You can have a tension pneumothorax. Just think of it as a lot more pressure, and it can rupture, right? Now, you can have a hemothorax. So every time you see pneumo is air, every time you see hemo is blood. So a hemothorax is the same with blood, right? Pericardial tamponade is the same as hemo, right? But in the pericardial sac. So all of these things go to, there's a bag, enveloping some organs, and they fill with something, and they don't let those organs move freely, and they contract. And these are organs that need to be expanding or pumping all the time, and if they don't, bad things happen. You can also have transphmotic asphyxia, so you can't breathe, and we talked about the sucking chest wound is an open wound to the chest by which air can come in. There are two membranes in the chest cavity. One covers the lung and the other lines the inside wall of the chest. What is normally found between these layers? A, a small space that contains only air, a small space that contains only a clear fluid lubricant that allows the lungs to move freely while they expand and contract, a small space that contains only blood, or all of the above. B, right? The longest. If you don't know anything about this, they took a lot of work to explain that one.
Can I just make one point?
Yeah.
These membranes, it's the same thing as the peritoneum.
That's the other side.
It's
right?
the exact same thing, except it's peritoneum's in the abdominal cavity,
And this is
pleura's
the
in the
thoracic.
chest.
Right.
That's why
Pleura actually means rib. The etymology of the word pleura is rib. All right, which of the following describes a flailing chest? Is defined as fracture of 3 or more adjacent ribs, each of which is fractured in 3 or more places. Is defined as fracture of 2 or more adjacent ribs, each of which is fractured in 2 or more places, results in the injured segment of the chest wall moving independently from the rest of the rib cage, both B and C. Oh, I didn't have it, it's B. And C. Yes, so it's D. So it's D, correct. That joke. When I asked my friends how he's doing, he said, man, I'm just happy to be breathing. I told him he should have bigger aspirations. And it was D. Got it wrong order. Gotta work on these animations. Okay, so we know the anatomy, the basic anatomy. You can read. Please do read more about it because there's going to be questions on the test. But hemoblood, pneumo, air, sacs, enveloping things. Pressure inside the sac, not good. All right. So assessment, like all assessments, assess ABCDs, always use PPE. Establish the mode of injury. Oh, I came and I fell on my chest and I hit a feature of the terrain part. Ooh, okay. Monitor ABCDs for possible future obstructions, internal bleeding, right? Secondary assessment, sample and OPQRST, it's all the same thing, right? Now, the things that you gotta watch out for symptoms of chest injuries. Eyes bulging, neck veins distended, somebody's trying to breathe really hard. Trachea deviated, right? So this might be a little over, coughing blood maybe, right? And the technique here, the acronym that comes with these injuries, look, auscultate, and palpate, right? So look, auscultate, listen, and palpate, touch. Of all of these, I would say look is really important, and here's why. Chest injury, you want, or abdominal injury, you want to see. You want to see what's going on, because it might not be bleeding, but if it's purple in a certain way, it tells you something. You want to expose that wound and check it out, right? Mostly if you assess the mode of injury being something like really, really tough, right? The acronym, who can tell me what decap bottles is? D. C. A. T. B. T.
Tenderness.
L.
Laceration.
S.
Perfect.
Okay. And then assess the sternum. Okay? This is really important. Assess the sternum. Now, this can be complicated if you're a male patroller assessing a female patient. So what you ask the patient, does anybody have or heard how to do this? Take their hand, put it here, and then you go doing like this. So we had a case one time that a girl hit the railing really hard. She was like 18 or 19, and I had to see her, and I wanted to palpate the sternum. She had, wrist pain and abdominal pain and whatnot. And then I told her to put the hand here, and then I went like this. And then I said, anything hurts? And she said, my wrist, because I took the wrong hand to do the thing because I was so nervous, right? So you don't want to do that, but the way to do it is, pay attention to the other injuries. But the way to do it is like, all right. Signs and symptoms of chest trauma. Okay, pain at the site of injury that's aggravated by breathing, of course, right? So if it's in your lungs, breathing is going to be painful. If you have ribs, pushing inside your lungs or any puncture, it's painful to breathe. Abnormal chest wall findings like a flailing chest, or hole or bubbles in the wound, or it doesn't matter how small it is, bubbles are not good. Dyspnea, so that's shortness of breath, right? Tachypnea, so breathing really fast. Like when you were breathing, I don't know if at the beginning when you were breathing like this, tach breathing, did you feel the need to like at the end go like, right? Because you really wanted to breathe faster and I didn't let you, right? But if you see somebody breathing faster, they actually have a problem, right? Absent or decreased breath sound. So for example, a lung can be collapsed. So one lung can be collapsed, and if you auscultate with the stethoscope, you might not hear breathing on that side, and you hear breathing on the other side, right? Cyanosis, that's blue skin color, right? That's also lack of oxygen. Hemoptysis, you just saw this, right? You're coughing blood. Tachycardia and failing, unfolding blood pressure, right? So either too fast, and the blood pressure is not good, something's ruptured there. You can get, I didn't mention this because, Kenny did this. Aneurysms can also happen, and really, most of this, if it broke your ribs, it's a load and go. There's so much that could have happened there, right? So an aneurysm is a fail, so, or on most cases. All right, management. How do we deal with this thing? So we just saw the assessment, we established a chest wound. If it's a pneumothorax, right, just put high flow of oxygen because their lungs are not working and their blood needs to oxygenate with whatever little lung movement there is, right? So just stick it to the man. Call ALS immediately. That would be true for all of these, okay? And monitor. Well, ALS is not in, monitor. When you find, in your scenarios, when you find a pneumothorax or any thoracic cavity injury, and you're on the hill and you're waiting for your patrol, monitor that guy, monitor that guy. There's not a lot you can do, monitor that guy, okay? Respiratory distress, load and go. Spine mobilization if necessary. It most likely is because the blunt trauma that has been received, it's so blunt that you probably should suspect at least the shaking of the head that was violent enough so that you want to immobilize. Commotion cardio, this is when, the sudden death, CPR, right? Somebody just hit something and a minute passes and then they fall down, CPR. Flailing chest, split the segments together, right? Above and below the fracture section. So if these are my fracture ribs, put a piece of pillow or something semi-stiff, right? And then patch it under and over the flailing chest. That's the best you can do before medical help arrives. What is the three-step process that OEC, again, bad dictation, that OEC technicians should use when assessing patients for chest trauma? What's the three-step? Listen, act, and palpate. Look, auscultate, and palpate. Listen, act, and percuss. Look, auscultate, and percuss. B, of course. That's there. And thorax, actually, is the breast, the chest, the breastplate. That's what thorax means from Latin. All right. How to treat an open chest wound. So the first thing you got to think of this is you don't want to put bandages or anything that is too permeable, right? You want to do occlusive dressing, and you want to tape it on three sides. Why? Exactly. You saw the bubbles. So the bubbles is there coming out. That goes out the occlusive dressing, and because it's occlusive, when you breathe in, nothing comes back in because the plastic seals that, right? So, are we doing this skill, Patrick? Because I didn't see it listed as a skill in the chapter, but I saw it listed as a skill in the syllabus.
The only one we use is this addressing on the neck.
Okay. All right, but that chest wound bubbles in a Ziploc bag if you don't have occlusive dressing. 3 pieces of tape around it. It doesn't matter which. Try to point it downwards, but it really doesn't matter. Just tape 3. And that is what I have before we go skills, because we need to do a lot of scenarios. I'm sorry. Any questions, guys? Comments, concerns? Flashing brilliant. All right, I think we're good. Okay.